Al Senato abbiamo un evento particolare, sappiamo quale shock sia stato per l'Italia l'epidemia Covid, con tutto quello che le è venuto dietro, le misure che sono state prese, le conseguenze sociali, mediche, economiche che ci sono state, con non poca difficoltà. Siamo riusciti ad approvare una legge per istituire una commissione parlamentare d'inchiesta sul Covid, la quale ha uno spazio sui mezzi di informazione inversamente proporzionale alla magnitudine di ciò che stiamo trovando. Abbiamo cominciato trovando mascherine comprate a prezzi più alti di quelli che pagavi, molto più alti di quelli che pagavi in farmacia a comprarne una, comprate a milioni. Abbiamo avuto contezza del fatto che il comitato tecnico scientifico, più che dare consigli al governo su cosa fare, dare consigli tecnici, scientifici al governo su cosa fare, recepiva gli input politici del governo per, come dire, in qualche modo giustificarli. Abbiamo anche visto in parallelo a queste mascherine, comprate a prezzi irragionevoli, arrivare in Italia flussi di denaro, in particolare a certe società nate da poco o la cui funzione era stata cambiata rapidamente in breve tempo. Abbiamo visto che le terapie che venivano usate non erano anch'esse frutto di indicazioni scientifiche e anzi esplicitamente non tenevano conto di studi scientifici approfonditi e accurati che erano stati fatti, al punto che tali studi risulta che non fossero conosciuti. Allora, finché uno studio o due, certo nessuno può sapere tutto, ma quando si scopre che tutti gli studi sull'efficacia di certi farmaci e tutti gli studi sulla inefficacia, anzi sulla dannosità di certi altri farmaci, e parlo sempre di terapie, diciamo che viene il sospetto su se veramente fosse tecnico-scientifico o qualche cos'altro, perché chi si occupa di tutt'altro è anche normale che non conosca l'evolversi degli studi scientifici, ma chi è lì per quello, in un'emergenza terribile, è quantomeno curioso che non ne conoscesse neanche uno. Bene, non voglio dilungarmi, intanto ringrazio tutti per la presenza, ringrazio in particolare il professor W.Malone, medico, biochimico, membro dell'ACIP, personaggio di grande prestigio che ha sempre detto ciò che gli risultava dalle sue conoscenze scientifiche, dallo studio che ha sempre continuato a fare, dai dati oggettivi che rilevavano. Dunque è stato marchiato come persona irragionevole e inattendibile perché non diceva ciò che altri dicevano senza avere alcun supporto scientifico. Dunque ovviamente o ha ragione uno o ha ragione l'altro. E naturalmente per chi aveva un altro approccio aveva torto il professor Malone, che ringrazio molto intanto per essere qui, perché non è certo, è appena arrivato, ha viaggiato tutta la notte, mi ha spiegato, dalla Florida al nord-est degli Stati Uniti e poi fino a Roma, ed eccolo qua, per cui già solo per questo si merita un grande applauso di tutti quanti. Ringrazio il Presidente della Carta di Siena, Sandro Sansevero, che è qui, che introdurrà. Ringrazio tutti per la collaborazione. Mi permetto di citare il dottor Alberto Donzelli, col quale abbiamo a che fare più spesso, ma tutti coloro che sono con lui. E allora dicevo, intanto per essere qui, ma soprattutto per il lavoro che viene fatto, che fanno, giorno per giorno, perché c'è davvero bisogno di persone che non hanno il timore di dire la cosa più difficile. Diceva Oscar Wilde che, se dite la verità, prima o poi vi scoprono. Ecco, questo è e questo dunque infatti a dimostrazione che può essere può essere rischioso, e per cui grazie per la presenza, grazie per la collaborazione. In ogni caso credo sempre, indipendentemente, io posso benissimo capire che la scienza è questo, è confronto fra tesi, è avere un'idea e magari difenderla fortemente anche di fronte ad altre che hanno grandi evidenze, ma la scienza progredisce, si raggiungono i risultati col confronto, non con le etichettature. Tu hai torto, tu sei seguono vari aggettivi, sei antiscientifico. No, se io non dico che chi la pensa diversamente da me in Parlamento è antipolitico, ha un'idea diversa dalla mia. Io cerco di far politica nel modo che ritengo, cerco di portare avanti le istanze che ritengo migliori. So bene che ci sono altri che hanno idee molto diverse, ma non è che io sono antipolitico per loro, loro sono antipolitici per me. Abbiamo opinioni diverse. Confrontandosi diamo modo agli altri di farsi un'idea e fra di noi magari di apprendere qualcosa dal prossimo. Credo che questo, almeno negli ultimi 500 anni, è la scienza. Poi c'è l'antiscienza, quello davvero, che è dire io ragione, tu torto, punto e basta. Questo non è scienza, è una sorta di dittatura o un infantile darsi ragione, che appunto è proprio l'opposto della scienza. Per cui grazie e buoni lavori. Io non riuscirò a restare molto a lungo perché abbiamo parecchie cose che bollono in pentola qui al Senato. Per cui grazie per la vostra presenza.
Grazie e benvenuti a tutti. Un ringraziamento particolare proprio al senatore Malan per aver consentito lo svolgimento del convegno in questa sede così prestigiosa e per le brillanti parole pronunciate, e mi ha tolto anche la difficoltà di dover presentare il nostro relatore principale, il dottor Malone. L'ha già fatto lui e quindi io non aggiungerò nient'altro alla fine per non sovrapporci. Mi consentirà anche l'amico Alberto Donzelli, che presiede e dirige la Commissione Medico-Scientifica Indipendente, di cui immeritatamente sono un componente, ma rilanciamo in questa sede quello che sono anni che diciamo, cioè un confronto, perché la medicina non è una scienza esatta, è una cosa empirica che si basa sul confronto e la rivalutazione costante che i dati siano effettivamente corrispondenti a ciò che accade sul campo. I dati provenienti dal mondo reale, non da modelli matematici o da ipotesi filosofiche in cui prendendo determinati parametri si arriva a determinati risultati che non significano niente. Permettetemi questa piccola digressione. La matematica per modelli è stata inventata dal grandissimo von Neumann, grande fisico e matematico, il quale per spiegare cos'era la matematica per modelli ai suoi allievi diceva: voi mi facciamo un modello matematico con 4 variabili e io vi descrivo un elefante. Se mi consentite di inserire nello stesso modello matematico una quinta variabile libera, vi dimostro col modello matematico che l'elefante vola. Quindi andiamoci piano con le proiezioni dai modelli matematici, poi bisogna vedere se i dati dal mondo reale coincidono oppure no. E allora sono anni in cui, come Commissione Medico-Scientifica Indipendente, ringrazio sempre il senatore Malan che ha sempre partecipato da remoto a tutti i convegni che abbiamo fatto, chiediamo il dibattito e confronto sulle prove, perché la medicina è basata sulle prove, e qualora durante il confronto ci venissero fornite prove di forza e validità superiori a quelle che presentiamo noi, saremo i primi ad ammettere che gli altri avevano ragione, perché noi non abbiamo la verità in tasca, non abbiamo dogmi, andiamo faticosamente alla ricerca della verità, per quanto è possibile conoscerla. E a questo punto farò una introduzione semplicemente metodologica, perché bisogna ricordarsi che la logica è un'etica del pensiero, è un'igiene del cervello, perché io posso pensare bene o pensare male, non solo per quello che penso, ma per come io penso. Se io vi dicessi che questo è un missile, voi mi direte mi stai prendendo in giro, perché quello non è un missile, è una penna. Cioè io non sto usando bene i miei neuroni cerebrali, la mia logica. Però ha la forma di un missile, ma non è un missile. Perché noi attribuiamo valore al significato delle parole, non alle parole. Anche perché la parola è solamente una parola. È il significato di ciò che noi cerchiamo di trasferire che è l'importante. E dalla corruzione delle parole, dalla corruzione del significato delle parole, si porta alla fine alla corruzione della scienza e alla corruzione dell'intera società. Tutti i medici hanno imparato qual è il significato della parola vaccino, che fino al 2021 era il seguente, perdonatemi se leggo perché non voglio sbagliare. La definizione era un prodotto che stimola il sistema immunitario di una persona a produrre l'immunità da una specifica malattia, proteggendo la persona da quella malattia. Nel 2021 il significato è stato cambiato in un preparato che è usato per stimolare la risposta immunitaria contro le malattie. Ma chi dice? Dov'è la prova che una risposta immunitaria sia sempre e comunque positiva? Qualcuno ha mai sentito parlare delle malattie autoimmuni, in cui è il sistema immunitario dell'organismo che aggredisce l'organismo stesso? Se non l'avete mai sentito parlare, vi dico artrite reumatoide, lupus eritematoso sistemico, possiamo continuare e non ha senso. Allora, però, tornando all'esempio del missile, se io definissi il missile come una aerodina priva di superfici alari, avviata mediante un lancio iniziale che percorre una rotta parabolica determinata, questo sarebbe un missile. Io lo lancio ed è un missile. Ok? Prego l'immagine. Perché se noi andiamo a vedere, ovviamente le categorie di sostanze attive con il corpo sono rigidamente normate, come è ovvio che sia. Se la lanci come si vede meglio. Ok. Allora, qui c'è la spiegazione per cui questo è un missile. Allora, questo è EMA, l'Agenzia Europea del Farmaco, per cui un prodotto genico, cioè una terapia genica, come dire, del materiale genetico, RNA o DNA, contenuto dentro nanoparticelle lipidiche, costituisce una terapia genica. Però, se questa struttura, fatta in quel modo, che funziona in quella modalità, ha quel meccanismo di azione, la utilizzo contro una malattia infettiva, non è più una terapia genica, ma è un vaccino. E questo per pura definizione, pura semantica. E quindi questo è un missile. Lo capite? Non è che se noi definiamo vaccino un qualche cosa, questo sia uguale ai vaccini che abbiamo imparato a studiare e che utilizziamo e che sono entrati in commercio dopo decenni di sperimentazione, e ci sono anche ancora tutta una serie di dubbi sulle possibili problematiche dei vaccini che stiamo usando da 50 anni sui bambini. Infatti la stessa legge Lorenzin prevederebbe che ogni 3-4 anni si rivalutasse, alla luce dei nuovi dati emergenti dal mondo, che cosa è successo, per eventualmente correggerla, proprio perché la medicina non è una scienza esatta e quindi dal mondo reale possono provenire dati differenti. Allora, quindi se noi chiamassimo per quello che è la sostanza contenuta nelle nanoparticelle lipidiche, cioè un profarmacogenico, la situazione sarebbe la seguente. Noi abbiamo questo prodotto, sappiamo che non previene l'infezione, non previene la trasmissione della patologia, ma crediamo che sia in grado di ridurre la gravità della tua malattia. Tu saresti disponibile a prenderti una dose di questo farmaco ogni 4 mesi o giù di lì affinché rimanga efficace? E se tu fossi disponibile a fare ciò, vorresti che ci fosse una legge che obbligasse tutti gli altri ad assumere questo farmaco per il resto della loro vita? Oppure lo assumeresti solamente per te? Attenzione, con sanzioni che erano l'impedimento non solo della vita sociale, ma della possibilità di guadagno e quindi di poter mantenere la dignità umana, di mantenere se stessi e la propria famiglia. Cioè, neanche agli ergastolani una cosa del genere. Allora, guardate che tutti questi elementi non sono usciti adesso, erano noti sin dall'inizio, sin dai trial preautorizzativi presenti in letteratura, prima dell'autorizzazione all'immissione condizionata in commercio. Non li abbiamo scoperti adesso, ma semplicemente che le autorità di controllo, a partire dalla Food and Drug Administration, all'EMA, l'Istituto Superiore di Sanità, AIFA, per arrivare all'ultimo ordine dei medici, hanno semplicemente mancato nella loro applicazione del mandato, che era quella di dubitare e di non affermare nulla di più che non fossero in grado di provare nel momento in cui lo affermavano. Okay. A questo punto non voglio continuare oltre, lascio la parola appunto al professor W.Malone, come già stato detto, l'inventore della tecnologia a RNA messaggero, per cui il Nobel l'hanno dato a quelli che l'hanno fatta modificato l'RNA messaggero, con tutta un'altra serie di problematiche che derivano dall'inserimento di una molecola, la pseudoridina, che la natura avrebbe scartato nella composizione del DNA, che poi porta a sua volta tutta una serie di problemi, tra cui un potenziale danneggiamento del sistema di trascrizione ribosomiale, per cui si possono creare in maniera indistinta delle proteine che non funzionano a niente, proprio abnormi, per un danneggiamento del sistema di trascrizione. E gli voglio chiedere all'inventore di questa metodologia se questa tecnologia sia sicura ed efficace, avendo presente un dato essenziale, che un cosiddetto vaccino noi lo somministriamo a un soggetto sano. Non è una terapia genica sperimentale, magari su un malato terminale di cancro, in cui con il consenso del paziente la medicina va avanti per tentativi. Cioè, io non ti voglio fare del male, ho fatto tutto quello che già conoscevo, siamo arrivati qui e quindi a questo punto sei d'accordo che sperimentiamo su di te questo tipo di avanzamento? E così la medicina va avanti. Ma un vaccino si dà a un sano, e quindi bisogna essere più che certi di non creargli la problematica. Perché vedete, un medico, e qui concludo, giura sull'etica, non giura sulla legge, né sulla Costituzione, giura di rispettare l'etica. E il primo principio dell'etica medica è primum non nocere. La prima cosa è non fare del male. Poi vedo se riesco a curarti, ma per prima cosa non devo essere io la causa di un possibile problema. E quindi sono efficaci e sicuri, perché magari sono io che sono rimasto indietro, perché nel millennio scorso, quando ho studiato nella facoltà di medicina e chirurgia, oltre il 90% del materiale genetico non si sapeva a cosa servisse. E quindi non è la lettura della sequenza nucleotidica che mi dice qualcosa, perché i geroglifici si leggevano da sempre, ma fino a che non abbiamo trovato la stele di Rosetta, non eravamo in grado di capire che cosa significassero quei geroglifici, quella sequenza di simboli. A questo punto ne sappiamo abbastanza sul patrimonio genetico per introdurre in questo meccanismo, che ai miei tempi era ignoto per oltre il 90%, dell'altro materiale genetico che interagisce, e siamo certi che sia sicuro ed efficace? Grazie Robert per la tua presenza e la disponibilità qui, e mi zittisco completamente.
So you wish me to react to what you just said? Of course, these are what you're sharing is something that many of us have been saying now for 4 years or more. Let's start with the issues about the underlying technology, because that's what you're asking me to comment on. I completely concur with you that this technology is fundamentally a gene therapy medical product applied to the specific application of producing an immune response against the encoded protein. It uses from a regulatory standpoint, the active drug substance, which is the RNA and the delivery system, is not the active material in terms of the medical, I hesitate to say therapeutic response. That this is a material in a technology that originated in one of the leading gene therapy labs in the world, that being Dr. Inder Verma's lab at the Salk Institute. I know that because I was there and this is what I did. And I was studying to be a gene therapist. That's what I wished to be, a pediatric gene therapist. But my research took me down this strange pathway of the idea of using RNA as a drug. So that was the origin, and in the same laboratory at the same time, the senior postdoc named Dinko Valerio, Dr. Dinko Valerio, was pioneering the use of recombinant adenovirus, this is a cold virus, for purposes of gene therapy. And that is, Dinko went on to create a company, I believe it was in the Netherlands, called Crucell, and initially focused on gene therapy, and then focused instead the company on vaccines. And that was the company that was purchased by Johnson & Johnson and gave rise to the Johnson & Johnson vaccine. That is another explicitly gene therapy technology applied to vaccination. So I completely agree with your core thesis that these are gene therapy technologies they can be used for many different things. One of the things they can be used for is to cause your body to make a foreign protein that will generate an adaptive immune response that one might call a vaccine under the definition of what is a vaccine. Now you spoke about the unanticipated side effects, let's say, of this particular technology as modified by Carrico and Weissman. You referred to the Nobel Prize, and what you're speaking of is changing from a natural RNA, which is what was in my original work, an RNA that was synthetic but as close as possible to a natural product, to a molecule which is truly synthetic. It is a modified messenger RNA. It's modified by the inclusion of a particular molecule called pseudouridine, and it's not just a natural pseudouridine, which isn't in It's present in many RNAs, pseudouridine is. It's placed in specific places. And one of the things that pseudouridine modification is used for by the cell, by our bodies, is to enable controlled frame shifting. It also changes the immune response to an RNA, the presence of pseudouridine, and it regulates how efficiently that RNA is turned into protein, and it regulates how long that RNA lasts in your body. When this modification was pioneered by Kuriko and Weissman, and they filed a patent, they didn't imagine that this could be used for vaccine purposes. That came later. They were focused more on cancer, like your comment. But this became useful as the industry decided that this idea of using RNA as a drug and using it for vaccine purposes would be productive and profitable. One of the problems, as you point out correctly, with the use of pseudouridine in the way that it's used, which is to put it all over in the RNA molecule in a non-natural way, and they're not even using the natural pseudouridine, they're using a modified chemical version. So these are truly modified mRNAs. Is that, number one, it creates an artificial molecule, it's not really RNA, that lasts for a very long period of time, and data are suggesting it may last for many months in your body. So that's more like DNA and DNA-based gene therapy. It's not like the original idea of a molecule that would be put into your body that would last for an hour or 2 hours and then be degraded. These molecules last for a very long period of time. Furthermore, by putting all those pseudouridines in, as you correctly point out, it causes frame shifting, which causes the production of proteins that we don't even know what they are, that seem to be very inflammatory and have nothing to do with the intended active drug product, the protein, in the case of spike, for instance. We don't even know what those proteins and protein fragments do. It may be that some of them are very similar to human proteins, and that may be part of what seems to be driving an autoimmune problem, which is one of the more common longer-term side effects we're now learning, which is the development of what may be an autoimmune damage to nerves and nervous system. Neuropathy, the data that are emerging suggests that this neuropathy may be more common than the myocarditis. And the physicians that are treating these patients with this vaccine-associated nervous system problem, including what's called POTS syndrome, find that it's extremely difficult to treat. One of the most challenging things that many physicians have ever encountered. It's not generally recognized as one of the adverse events, but now in American research and in what we're learning at the Advisory Committee on Immunization Practices, it's becoming clear that it is unfortunately rare, but still significant. Now, I need to take a moment and say something important. I'm here in my private capacity. Although I serve as a government employee under Secretary Kennedy at his appointment for the CDC and the Advisory Committee on Immunization Practices, where I'm the co-chair, I'm not speaking on behalf of the government, of the CDC, or the ACIP. I'm speaking in my own capacity right now. I just want to be clear on that. But this problem of the neuropathy may be related to this frame shifting. The longevity of the RNA clearly is associated with the pseudouridine modification. And I think it's important to recognize that what is being administered to patients is not natural RNA at all. It's a synthetic molecule that can be turned into protein like RNA does, but it is not RNA. It has a number of characteristics, and it may be that there are aspects of pseudouridine modification which is still not really understood in the molecular biology. The molecular biology of pseudouridine in the biochemistry is still an emerging science. We don't really understand it very well, but it appears that one of the effects of that may even relate to mitochondrial function. So we seem to have a number of things that, as you correctly point out, are counterproductive for the patient, never been seen before with any vaccine-like product, and some of those I see in your text here. You're mentioning the possibility of premalignancies or other problems. Those data seem to be emerging now, now that we've had a long period of time since the RNA was administered. Now, there's another issue that you have not yet touched on, but I know you're very aware of, which is that the manufacturing process that is used in producing these RNAs is based on, it takes the DNA to make the RNA. And it's using a circular form of DNA purified from bacteria called a plasmid. And the delivery system, the lipid nanoplex that's used to deliver the RNA into your cell, also delivers DNA. It was in fact first invented for DNA purposes, and then I adapted it for RNA purposes back in the late 1980s. But it delivers DNA just as well as it delivers RNA. And unfortunately, the emerging data from many laboratories all over the world is that these products have significant levels of leftover DNA fragments from the manufacturing process, in which this circular DNA is cut into small pieces so that it's, in theory, no longer active. But the manufacturing purification process is not sufficiently efficient to get rid of those DNA fragments. And so those DNA fragments are being delivered together with the RNA into your body when you accept these products. That's not intended. It was not revealed as a characteristic of the drug. And so technically, I argue that it represents, from a regulatory standpoint, what is called adulteration. It's a contaminant in the product that isn't supposed to be there, wasn't revealed to be there. And as I mentioned, laboratories all over the world, including in EMA, have confirmed that this impurity is present. So why does that matter? Because the particles deliver the DNA just as well as they deliver the RNA, it means that your cells are receiving both small DNA fragments and RNA. Unfortunately, small DNA fragments are what the technical term is highly recombogenic. What that means is they are readily transported into the nucleus and insert themselves into the chromosome. So we have a clear mechanism of action we have a clear documentation of contamination with these small DNA fragments, and we have a risk of genomic alteration associated with these products that was not anticipated, was not disclosed. Doctors didn't know. They had no way of knowing this. This is new technology. Many of the regulators didn't insist on the proper testing to detect whether or not those DNA fragments were there. So if it's anybody's fault, I guess it's the regulators for not doing their job, or perhaps the pharmaceutical industry for not being rigorous, but it's certainly not the fault of physicians or public health officials who had no way of knowing that this DNA contamination was there. Is it a problem? Is it a clinically significant problem? Because that's the only thing that matters. If the DNA contamination is there, but it doesn't cause sickness, then it's not really a major problem. What kind of sickness could it cause? DNA fragments that insert. The concern is that it may give rise to cancers. And unfortunately, there are signals in the data suggesting there may be an increase in cancer after the onset of the vaccination campaigns. But there are many things that can cause cancer. Just like there's many things that can cause excess death, all-cause mortality. For instance, to talk about all-cause mortality, we had, in the global response to this virus, we had policies about social isolation of individuals, policies about protecting people from each other, policies about isolating the elderly, policies about, for good reason, for good-hearted reason, to take the elderly into the hospitals and then to quarantine them and isolate them. But that results in depression, and depression results in death, particularly in the elderly. So maybe this was just an unfortunate consequence of a public health policies that were well-intended, but led to excess death as much from mismanagement as from the virus itself. So we have to be very careful when we look at increases in all-cause mortality, whether it's from the virus or potentially associated with the vaccine or potentially a cancer signal, that we're very clear that there may be multiple causes. But the data that we're seeing at the Advisory Committee on Immunization Practices is raising serious questions that there may be a variety of forms of sickness associated with the vaccines, usually rare, just like the myocarditis is rare. Not everybody gets it, but a significant number of people do. And it may be that it appears that a significant number of people, maybe more than the myocarditis, may be getting these neurologic syndromes, like POTS, that are very debilitating to those few that have them. And so then the question becomes, how much benefit are these products providing? How serious was this virus, really? How much of the death and disease was due to mismanagement, and how much was actually due to the virus? It's hard to say. The data are starting to suggest, and really increasingly, Dr. Bhattacharya, the new director of NIH, did early studies that showed that the death from the virus was very, very rare, a fraction of a percent, much lower than what was publicized by the WHO and corporate media. So it looks like, in hindsight, that the virus wasn't that deadly. So then we applied a series of vaccine products that were gene therapy products, and unfortunately, it looks like, to the extent they provided any benefit, the data are increasingly suggesting that there may have been more harms, particularly in the young, associated with those products, than benefits, because the young generally did not get very sick. They didn't die. So now we have a problem as we look back, and Italy and EMA and the United States, Secretary Kennedy, President Trump, need to make, and the World Health Organization, need to make policy decisions going forward so we don't make the same mistakes. And key questions are whether or not this technology, this gene therapy technology involving synthetic mRNA, is going to be an effective way to rapidly counter the risks of new emerging infectious disease if and when they happen. Is this the best solution? Or do we need to start looking more at more traditional technology and maybe some other new technology? Maybe this isn't the perfect technology. We need to ask those questions, and we need to ask the question, was the response in which physicians that are here developed early treatment therapies with existing drugs that prevented death and severe sickness, but they weren't allowed to talk about it, with this focus just on vaccine solutions for infectious disease? Is that really the best practice? Or is it better policy that we carefully listen to frontline physicians that are actually treating patients and learning from that treatment how to prevent sickness and death, maybe instead of censoring them and preventing their voices from being heard, maybe we need to find ways to amplify those voices, to listen to them very carefully. So those are my thoughts and remarks in response to your opening, which was very comprehensive and I believe absolutely correct. And I'm glad to answer any of the questions you may wish to have.
Grazie. Infatti il premio Nobel lo hanno dato a chi ha seguito le leggi naturali, ma a chi ha creato tecnologie artificiali che creano proteine artificiali che alterano il funzionamento interno del corpo in una maniera che non siamo in grado di poter minimamente prevedere. Guarda questo. Un'altra cosa, Robert, un altro aspetto su cui vorrei che puntualizzassi tu, che sempre i vaccini classici, ad esempio l'antitetanica, prevedono che la sostanza sia resa inattiva, cioè non inietto nella persona la tossina tetanica per avere la reazione, ma gli inietto la anatossina. Allora, questa proteina spike, con tutto quello che ci sta prima di poter arrivare alla sintesi, alla esposizione, e poi un'altra cosa che è chiara è che la cellula naturale che espone degli antigeni non naturali viene riconosciuta dal sistema immunitario, qualora funzioni correttamente, come non self, non appartenente all'organismo e quindi attaccata e distrutta. Ora, ci sono cellule, se fossero rimasti dentro il deltoide muscolare, perdi qualche fibra del deltoide, vabbè, funziona lo stesso. Ma dato che diffondono le nanoparticelle lipidiche ovunque, anzi hanno un tropismo particolare verso determinate strutture. Hai parlato del sistema nervoso centrale, ma io aggiungerei il cuore e le gonadi, quindi con tutta la problematica di mutazioni genetiche in strutture destinate alla riproduzione e quindi bambini geneticamente modificati dalla nascita senza sapere come. Però volevo concentrarmi, poi andremo su questi altri aspetti se ci sarà tempo, sul fatto, ma questa spike è stata inibita o è biologicamente attiva? Cioè l'organismo è portato a sintetizzare una tossina biologicamente attiva o sintetizza un qualche cosa che non è biologicamente nocivo per l'organismo?
So, to recap, you wish to focus on spike.
Yes.
And the biology of spike. And we're referring to a protein from the coronavirus that sits on its outer aspect. So, and by the way, all of you, even before COVID, were infected with a coronavirus that had a spike-like protein. Okay, these were naturally circulating. We called them colds. There's something about the spike associated with SARS-CoV-2 that seems to be particularly more toxic than that associated with the beta coronaviruses, which are the cold viruses. The spike that is used in the vaccines historically has been modified. It's modified for the biochemists in the audience that are listening at two particular prolines. And you can think of this spike molecule as having a glove. It has a pocket that binds to the target on the surface of the cell and allows the virus to attach. That's its function. It's a key part of virus infection of cells. That's what the spike does. Among the proteins that it interacts with are called ACE2 and TMPRSS. That's small details that the cell biologists will understand the importance and the physicians will understand the importance. The spike that is being produced from the gene therapy products, which includes adenovirus and RNA, is modified to lock it into an open conformation. Normally, when it binds, it closes, but it's modified so it stays open. Why did they do that? They did it because they knew that antibodies directed against the inside of the spike protein would be more likely to block its ability to infect, block the ability of the virus to infect. So that's why they did it. They didn't do it because they wanted to kill people. They did it because they thought it would make the spike protein more immunogenic in a good way. But what it does is it preserves the spike protein in a conformation that retains a number of its biologic activities which are toxic. So this gets to the point that I said early on but was censored for, back in 2021, that spike is a toxin. I say spike is a toxin because it causes toxicity, a variety of different kinds of toxicity. We don't completely understand that toxicity, but it includes, you point to the myocarditis. The physicians in the audience will know that they can measure enzymes which show damage to the heart are being increased almost immediately after those vaccine products are administered. That means it's not an autoimmune problem, it's a direct toxicity problem. You're absolutely correct that the data, going back to the rat studies and the initial data packages from Moderna and Pfizer, showed that these particles accumulate in the gonads, particularly female ovaries, also in the brain, and many other organs, including liver, all across the body. They don't stay at the site of injection. That promoted narrative was a lie. It was false. They go all over your body. And they, as you correctly say, they cause the cells in those tissues to produce spike protein. And we now know they produce spike protein in many cases for months in some patients. There's a Yale study that shows almost up to a year of production. So you have a long-lived, toxic spike protein circulating and being produced in cells all over your body. That's true. That's undeniable. That's the science. Is this the main cause of the toxicity, the spike protein that's being produced? So we have some interesting new data about that. Moderna has produced a new vaccine product, a new mRNA vaccine product called mNEXSpike. And mNEXSpike is engineered so that the spike protein is no longer biologically active. And yet it still seems to have just as much toxicity as the vaccines that had the biologically active spike. So that teaches to us that there's another source of toxicity, not just the spike. And that may well be the lipid nanocomplex together with the RNA, together with the pseudouridine. We don't know yet, but it looks like it's not just spike. So those data are coming out now, and there's been a couple of papers published about mNEXSpike, and unfortunately, it doesn't look like it stops the toxicity. So that's what I can say about that. It also appears that whether it's the spike protein or it's these short frame-shifted proteins are generating an autoimmune response in many patients. And this neuropathy that I talk about and POTS syndrome that is perplexing to so many physicians that are treating the small number of patients, but they're patients that suffer deeply. That appears to be more of a autoimmune phenomena or some sort of a delayed adverse event. And it doesn't happen in everybody, just like the myocarditis. It doesn't, I'm not in any way saying that everybody is going to develop this problem, but those patients that have developed this problem many of them suffer deeply. For long periods of time, the pain in some patients is so severe that they commit suicide. So that, I think, one of the things that as physicians and public health officials we should think about is acknowledging that these patients that have been damaged exist. And they exist in part because the state required these products to be administered. And yet, in the United States, the state also prevented the manufacturers from having any liability for this problem. And so, in a sense, the state assumes responsibility for these patients. And I think that that public health in the United States and across the world would be better served as a discipline if it would stop denying that these patients exist and recognize they do. They're relatively rare but severely injured in many cases, and take responsibility for trying to help these patients as physicians, as public health officials, So those are my comments. I hope, have I
That's
covered
not
the
medicine.
topics that you
That's
asked me to
coercion.
cover?
It's immoral. It has no place in a constitutional democracy or in a system that claims to protect.
Grazie. Nel mentre ti hanno portato un altro caffè perché,
Never on a financial bonus or a government
perché
mandate.
non ha dormito, è venuto, ha viaggiato tutta la notte per essere qui. Grazie. Introduco un'altra domanda, poi basta, e poi dopo la risposta prenderemo eventualmente le domande dal pubblico, perché adesso fondamentalmente per una riduzione di costi hai già correttamente detto che questa spike viene prodotta per mesi. Essendo stato catalogato per definione semantica nella categoria vaccini, non solo non sono stati fatti studi di cancerogenicità, genotossicità, perché è un vaccino, ma non si sono fatti neanche studi di farmacocinetica e farmacodinamica. Quindi non si sa qual è l'emivita della sostanza, cioè per quanto tempo e in quale quantità viene prodotta. Adesso abbiamo introdotto un'altra modalità per ridurre i costi di produzione dell'azienda, i famosi autoreplicanti, in cui fondamentalmente questa quantità di RNA modificato si comporta, perché è derivato da un tipo particolare di virus, l'alfavirus, particolarmente studiati, che come un virus si replica, e invece di replicare il patrimonio genetico del virus replica l'RNA modificato, come l'alfavirus, che alcuni tipi non hanno neanche il capside, quindi proprio sono materiale RNA così sparso. E quindi in questi, per quanto tempo si riprodurrà? Qual è la quantità che viene prodotta? Quali sono gli effetti? Cioè ci sono dati? E soprattutto, cosa ne pensi di quel fenomeno teorico dello shedding? Cioè della possibilità che la cellula, essendo intossicata da questa quantità di RNA modificato, lo incapsuli a sua volta in strutture appunto di membrane liposomiali e lo espella nello spazio extracellulare. Dato che pare che si accumuli a livello dei polmoni, sarebbe altrettanto facile.
Hi, I'm Robert F. Kennedy Jr., you're HHS Secretary. Let me ask you something. Should doctors make decisions based upon what's best for their patients or based upon what makes them the most money? It's not a tough question, but we've inherited a healthcare system.
Sarebbe, posso riprendere? Tutto a posto? Ok. Sarebbe altrettanto facile pensare, a quasi a una vaccinazione spontanea, o meglio di passaggio di materiale genetico da un soggetto all'altro attraverso il respiro. Possibilità teorica, ma è stata minimamente analizzata questa potenzialità di impatto nel mondo reale?
Today I'm proud to announce we've eliminated that policy by repealing a dangerous Biden-era
You speak of the next wave of RNA technology that is being deployed worldwide, beginning in Japan, of self-replicating RNA based on alphavirus replicons. And I'm very familiar with this technology. It has been in development.
Altered based upon childhood vaccination rates. That's not medicine. That's coercion. It's immoral. It has no place in a constitutional democracy or in a system that claims to protect children. Medical decisions should be made based upon one thing and one thing only: the well-being of the patient, never on a financial bonus or a government mandate. Patients deserve honest, uncorrupted advice from their doctors. Doctors deserve the freedom to use their training and to follow the science and speak the truth without fear of punishment. Doctors should be guided by medical judgment and their Hippocratic oath, not by financial incentives or government mandates. That's what this policy change is about, and it's just the beginning. Thank you very much. Hi, I'm Robert F. Kennedy, Jr., your HHS Secretary. Let me ask you something. Should doctors make decisions based upon what's best for their patients or based upon what makes them the most money? It's not a tough question, but we've inherited a healthcare system that constantly pushes doctors toward the latter. It rewards certain treatments not because they're better for the patient, but because someone profits. Take what happened during COVID. Hospitals were paid to report staff vaccination rates. Those numbers were fed into the National Healthcare Safety Network, then published on the CDC website to shame any hospital that refused to become an enforcer of federal vaccine mandates. Today, I'm proud to announce we've eliminated that policy by repealing a dangerous Biden-era provision in the CMS inpatient payment rule. And we're not stopping there. We're scanning every corner of the healthcare system for hidden incentives that corrupt medical judgment. What we're finding is alarming. Doctors are being paid to vaccinate, not to evaluate. They're pressured to follow the money, not the science. We've recently uncovered that more than 36,000 doctors had their Medicare reimbursements altered based upon childhood vaccination rates. That's not medicine. That's coercion. It's immoral. It has no place in a constitutional democracy or in a system that claims to protect children. Medical decisions should be made based upon one thing and one thing only, the well-being of the patient, never on a financial bonus or a government mandate. Patients deserve honest, uncorrupted advice from their doctors. Doctors deserve the freedom to use their training and to follow the science and speak the truth without fear of punishment. Doctors should be guided by medical judgment and their Hippocratic oath, not by financial incentives or government mandates. That's what this policy change is about, and it's just the beginning. Thank you very much. Hi, I'm Robert F. Kennedy, Jr., your HHS Secretary. Let me ask you something. Should doctors make decisions based upon what's best for their patients or based upon what makes them the most money? It's not a tough question, but we've inherited a healthcare system that constantly pushes doctors toward the latter. It rewards certain treatments not because they're better for the patient, but because someone profits. Take what happened during COVID. Hospitals were paid to report staff vaccination rates. Those numbers were fed into the National Healthcare Safety Network, then published on the CDC website to shame any hospital that refused to become an enforcer of federal vaccine mandates. Today, I'm proud to announce we've eliminated that policy by repealing a dangerous Biden-era provision in the CMS inpatient payment rule. And we're not stopping there. We're scanning every corner of the healthcare system for hidden incentives that corrupt medical judgment. What we're finding is alarming. Doctors are being paid to vaccinate, not to evaluate. They're pressured to follow the money, not the science. We've recently uncovered that more than 36,000 doctors had their Medicare reimbursements altered based upon childhood vaccination rates. That's not medicine. That's coercion. It's immoral. It has no place in a constitutional democracy or in a system that claims to protect children. Medical decisions should be made based upon one thing and one thing only, the well-being of the patient, never on a financial bonus or a government mandate. Patients deserve honest, uncorrupted advice from their doctors. Doctors deserve the freedom to use their training and to follow the science and speak the truth without fear of punishment. Doctors should be guided by medical judgment and their Hippocratic oath, not by financial incentives or government mandates. That's what this policy change is about, and it's just the beginning. Thank you very much.
Can
HHS Secretary, let me ask you something. Should doctors make decisions based upon what's best for their patients or based upon what makes them the most money? It's not a tough question, but we've inherited a healthcare system that constantly pushes doctors toward the latter. It rewards certain treatments not because they're better for the patient, but because someone profits. Take what happened during COVID. Hospitals were paid to report staff vaccination rates. Those numbers were fed into the National Healthcare Safety Network, then published on the CDC website to shame any hospital that refused to become an enforcer of federal vaccine mandates. Today, I'm proud to announce we've eliminated that policy by repealing a dangerous Biden-era provision in the CMS inpatient payment rule. And we're not stopping there. We're scanning every corner of the healthcare system for hidden incentives that corrupt medical judgment. What we're finding is alarming. Doctors are being paid to vaccinate, not to evaluate. They're pressured to follow the money, not the science. We've recently uncovered that more than 36,000 doctors had their Medicare reimbursements altered based upon childhood vaccination rates. That's not medicine. That's coercion. It's immoral. It has no place in a constitutional democracy or in a system that claims to protect children. Medical decisions should be made based upon one thing and one thing only, the well-being of the patient, never on a financial bonus or a government mandate. Patients deserve honest, uncorrupted advice from their doctors. Doctors deserve the freedom to use their training and to follow the science and speak the truth without fear of punishment. Doctors should be guided by medical judgment and their Hippocratic oath, not by financial incentives or government mandates. That's what this policy change is about, and it's just the beginning. Thank you very much. Hi, I'm Robert F. Kennedy, Jr., your HHS Secretary. Let me ask you something. Should doctors make decisions based upon what's best for their patients or based upon what makes them the most money? It's not a tough question, but we've inherited a healthcare system that constantly pushes doctors toward the latter. It rewards certain treatments not because they're better for the patient, but because someone profits. Take what happened during COVID. Hospitals were paid to report staff vaccination rates. Those numbers were fed into the National Healthcare Safety Network, then published on the CDC website to shame any hospital that refused to become an enforcer of federal vaccine mandates. Today, I'm proud to announce we've eliminated that policy by repealing a dangerous Biden-era provision in the CMS inpatient payment rule. And we're not stopping there. We're scanning every corner of the healthcare system for hidden incentives that corrupt medical judgment. What we're finding is alarming. Doctors are being paid to vaccinate, not to evaluate. They're pressured to follow the money, not the science. We've recently uncovered that more than 36,000 doctors had their Medicare reimbursements altered based upon childhood vaccination rates. That's not medicine. That's coercion. It's immoral. It has no place in a constitutional democracy or in a system that claims to protect children. Medical decisions should be made based upon one thing and one thing only, the well-being of the patient, never on a financial bonus or a government mandate. Patients deserve honest, uncorrupted advice from their doctors. Doctors deserve the freedom to use their training and to follow the science and speak the truth without fear of punishment. Doctors should be guided by medical judgment and their Hippocratic oath, not by financial incentives or government mandates. That's what this policy change is about, and it's just the beginning. Thank you very much. Hi, I'm Robert F. Kennedy, Jr., your HHS Secretary. Let me ask you something. Should doctors make decisions based upon what's best for their patients or based upon what makes them the most money? It's not a tough question, but we've inherited a healthcare system that constantly pushes doctors toward the latter. It rewards certain treatments not because they're better for the patient, but because someone profits. Take what happened during COVID. hospitals were paid to report staff vaccination rates. Those numbers were fed into the National Healthcare Safety Network, then published on the CDC website to shame any hospital that refused to become an enforcer of federal vaccine mandates. Today, I'm proud to announce we've eliminated that policy by repealing a dangerous Biden-era provision in the CMS inpatient payment rule. And we're not stopping there. We're scanning every corner of the healthcare system for hidden incentives that corrupt medical judgment. What we're finding is alarming. Doctors are being paid to vaccinate, not to evaluate. They're pressured to follow the money, not the science. We've recently uncovered that more than 36,000 doctors had their Medicare reimbursements altered based upon childhood vaccination rates. That's not medicine. That's coercion. It's immoral. It has no place in a constitutional democracy or in a system that claims to protect children. Medical decisions should be made based upon one thing and one thing only: the well-being of the patient, never on a financial bonus or a government mandate. Patients deserve honest, uncorrupted advice from their doctors. Doctors deserve the freedom to use their training and to follow the science and speak the truth without fear of punishment. Doctors should be guided by medical judgment and their Hippocratic oath, not by financial incentives or government mandates. That's what this policy change is about, and it's just the beginning. Thank you very much. Hi, I'm Robert F. Kennedy, Jr., your HHS Secretary. Let me ask you something. Should doctors make decisions based upon what's best for their patients or based upon what makes them the most money? It's not a tough question, but we've inherited a healthcare system that constantly pushes doctors toward the latter. It rewards certain treatments not because they're better for the patient, but because someone profits. Take what happened during COVID. Hospitals were paid to report staff vaccination rates. Those numbers were fed into the National Healthcare Safety Network, then published on the CDC website to shame any hospital that refused to become an enforcer of federal vaccine mandates. Today, I'm proud to announce we've eliminated that policy by repealing a dangerous Biden-era provision in the CMS inpatient payment rule. And we're not stopping there. We're scanning every corner of the healthcare system for hidden incentives that corrupt medical judgment. What we're finding is alarming. Doctors are being paid to vaccinate, not to evaluate. They're pressured to follow the money, not the science. We've recently uncovered that more than 36,000 doctors had their Medicare reimbursements altered based upon childhood vaccination rates. That's not medicine. That's coercion. It's immoral. It has no place in a constitutional democracy or in a system that claims to protect children. Medical decisions should be made based upon one thing and one thing only: the well-being of the patient, never on a financial bonus or a government mandate. Patients deserve honest, uncorrupted advice from their doctors. Doctors deserve the freedom to use their training and to follow the science and speak the truth without fear of punishment. Doctors should be guided by medical judgment and their Hippocratic oath, not by financial incentives or government mandates. That's what this policy change is about, and it's just the beginning. Thank you very much. Hi, I'm Robert F. Kennedy, Jr., your HHS Secretary. Let me ask you something. Should doctors make decisions based upon what's best for their patients or based upon what makes them the most money? It's not a tough question, but we've inherited a healthcare system that constantly pushes doctors toward the latter. It rewards certain treatments not because they're better for the patient, but because someone profits. Take what happened during COVID. Hospitals were paid to report staff vaccination rates.
Un prodotto pseudo-sperimentale, vengono assunti con stipendi elevati dalla stessa casa farmaceutica a cui hanno autorizzato precedentemente il farmaco. Credo che se ne uscirà solamente ribadendo il valore dell'etica dell'etica al di sopra di qualsiasi cosa, perché alla fine è solamente l'uomo che decide tra il bene e il male, se comportarsi in un modo o comportarsi in un altro. Non servono tanto le regole, serve l'educazione, perché, come si dice in Italia, fatta la legge, trovato l'inganno, per poterla bypassare. Volevo stimolarti sullo shedding e la possibilità che i vaccini siano così in generale. Mi sposto su un altro aspetto che potrebbe sembrare sganciato, ma ad esempio in Florida, dove vieni, con le zanzare geneticamente modificate, cioè erano decenni che non c'erano casi di malaria, si sono modificate le zanzare, come si fa in Italia a Terni, per renderle geneticamente modificate, e dopo che si sono rilasciate zanzare geneticamente modificate per prevenire la malaria, che erano decenni che non se ne registravano casi, sono apparsi nuovi casi di malaria. Che ci dici? Non tanto sulla malaria quanto sull'utilizzo di vettori geneticamente modificati, non si sa fare che cosa, che arrivano e ti punzecchiano tipo le zanzare.
The technology that you're talking about, these modified insects which suck blood, because there's more than just mosquitoes that do that. Generally, the focus has been on producing insects that are reproductive dead ends, so that they would breed with other mosquitoes and result in dropping the overall mosquito population. But with the development of that technology, as you know, technologists will do what they do. And once they learn how to modify an organism, whether it's a plant, a insect, or a human, they will often say, okay, well, now that we've done that, what else can we use it for? And so the genetic modification to breed mosquitoes that are reproductive dead ends has also led to the research development of mosquito populations that could potentially deliver antigens, vaccines, essentially, to those that they bite. And that, again, is another case of a technology in which a medical procedure, vaccination, would be performed without the consent of the person receiving it, and without even disclosure of any of the risks associated with it. You would just get bitten by a mosquito. You wouldn't know if it's a vaccine mosquito or just a regular blood-sucking mosquito or one that carries dengue or malaria or God only knows what else, chikungunya. I believe that this is another case of inadequate regulatory oversight and an example of a core problem that we have that also relates to the gain-of-function research, which is that we do have a cadre. There are those scientists. There have always been those scientists, just a small subset, that believe that if it's possible to do something, it should be done. And in many cases, they believe they're the ones that should be doing it because they're the best and the brightest, and the likes of you and I don't have enough knowledge to be able to properly make decisions about whether or not they should be doing those things. So this is, this classic mad scientist that will do crazy things. Is that happening with the recombinant mosquitoes? did it happen, and is it happening with gain-of-function research? Absolutely. In my opinion, those types of technologies should be subject to a revised biowarfare treaty. I personally believe that the time has come that the nations of the West and the world have had enough experience with gain-of-function research and genetic modification that just as there was a consensus in the 70s when recombinant DNA was first developed, that researchers would be very careful in applying recombinant DNA technology, very aware of the potential risks. I think it's time now for the world community to come together and make decisions about whether or not we wish to allow these types of studies to proceed. And thank you, I appreciate that. It's something that I have a personal commitment to, and if I have an opportunity to advance that agenda in the United States government, I will do so. But I think that it's the new policy, not speaking on behalf of the State Department, but quoting them, the new policy of the Trump administration is to work in a bilateral fashion with other nations, rather than having the U.S. tell other nations what they should be doing in the area of public health and infectious disease. And I think that consistent with that is an opening for the world community. Instead of focusing on international health regulations that will give more power to the World Health Organization in future pandemics, the World Health community, whether it's WHO, as you know, my government has decided to withdraw from the WHO. Your government has decided to not endorse the modified pandemic treaty and the international health regulations, which I can tell you Americans are very grateful for the decision of Giorgia Meloni and your current government to join the United States in dissenting. But I think there's an opportunity for Europe and America to come together and provide leadership in addressing the risks associated with this kind of recombinant research, whether it's modified insect vectors or it's modified viruses. I don't think that what we can see is the risk-benefit ratio for modifying coronavirus to see what it would take to make it more infectious was not there. There was far more damage done consequent to that research, because I think the data are clear that the SARS-CoV-2 was an engineered product. And personally, I think that the data are clear that the United States played a significant role in that. It wasn't just the Wuhan Institute of Virology. And public disclosures demonstrate that there is strong interest in members of Congress and in this administration to seek disclosures about, further disclosures about what went on. There's no question that Dr. Fauci was involved, was aware, did consent to this funding, did misrepresent the truth to Senator Rand Paul in the U.S. Congress. In other words, he lied under oath. And perhaps that's part of the reason why former President Biden gave him indemnification. That logic that Dr. Fauci was a key proponent of, I think really needs to be subjected to international scrutiny. And the people that promoted that and were the cause of the emergence of this virus and the damage that it caused to Italy, to your elderly, to people all across the world, I think they need to be held accountable. And I can tell you that in the United States, there is a growing movement to hold those responsible accountable, including Dr. Fauci, at the level of the states and at the level of the U.S. Congress, referring him for investigation to the Attorney General, Pam Bondi. So I'm confident that we will have more information about how this happened, and maybe that could be a starting point for a broader international discussion on whether or not this type of research should be treated like research into the development of thermonuclear weapons. I personally believe that we need a monitoring commission akin to what the world has agreed to in thermonuclear weapon control that would assess and verify that these practices aren't happening, or if they are happening, they're happening in a responsible fashion. So is it possible that, getting back to your example, that an intervention in nature with good intentions, let's assume good intentions, to reduce the risk of malaria, might inadvertently cause an increase? Absolutely. As you know, immunologically that can happen. We talk about immune imprinting and original antigenic sin. Those are key issues that are coming up in, I can tell you, in the ACIP discussions, the Advisory Committee on Immunization Practices. We're looking at those things. There are data now from large studies in the United States indicating that influenza vaccination in the last year may actually make you more susceptible to influenza disease. We call that negative effectiveness. So is it possible that something with this intervention caused an increase in malaria? It's absolutely possible. So should we deny that possibility? Or should we say, hey, maybe this risk has happened and we should better understand it. We shouldn't just deny it and pretend that it didn't happen. Have I addressed your question?
Perfettamente. Hai risposto perfettamente. Ora, Andrea, il video, ora abbiamo un'ospezione di qualche minuto del segretario Kennedy. Non si sente.
Today, I'm proud to announce we've eliminated that policy by repealing a dangerous Biden-era provision in the CMS inpatient payment rule. And we're not stopping there. We're scanning every corner of the healthcare system for hidden incentives that corrupt medical judgment. What we're finding is alarming. Doctors are being paid to vaccinate, not to evaluate. They're pressured to follow the money, not the science. We've recently uncovered that more than 36,000 doctors had their Medicare reimbursements altered based upon childhood vaccination rates. That's not medicine. That's coercion. It's immoral. It has no place in a constitutional democracy or in a system that claims to protect children. Medical decisions should be made based upon one thing and one thing only: the well-being of the patient, never on a financial bonus or a government mandate. Patients deserve honest, uncorrupted advice from their doctors. Doctors deserve the freedom to use their training and to follow the science and speak the truth without fear of punishment. Doctors should be guided by medical judgment and their Hippocratic oath, not by financial incentives or government mandates. That's what this policy change is about, and it's just the beginning. Thank you very much. Hi, I'm Robert F. Kennedy Jr., your HHS Secretary. Let me ask you something. Should doctors make decisions based upon what's best for their patients or based upon what makes them the most money? It's not a tough question, but we've inherited a healthcare system that constantly pushes doctors toward the latter. It rewards certain treatments not because they're better for the patient, but because someone profits. Take what happened during COVID. Hospitals were paid to report staff vaccination rates. Those numbers were fed into the National Healthcare Safety Network, then published on the CDC website to shame any hospital that refused to become an enforcer of federal vaccine mandates. Today, I'm proud to announce we've eliminated that.
Con qualche difficoltà tecnica, comunque il messaggio era estremamente chiaro. Ci abbiamo girato in tondo entrambi a lungo e abbiamo lasciato al segretario per gli italiani, al ministro Kennedy, appunto evidenziare che alla fine solamente l'etica potrà salvare la situazione, cioè per il medico deve essere indifferente dal punto di vista economico, dal punto di vista di avanzamento di carriera e da quant'altro, dover scegliere un percorso o un altro, ma essere totalmente focalizzato sulla tutela della salute del paziente che ha davanti, così come ha espressamente giurato per aderire all'ordine, perché è un ordine, perché deriva dagli ordini monastici. Se tu vuoi appartenere alla categoria dei benedettini, dei francescani, eccetera, devi seguire queste regole etiche. E cosa deve fare il medico è scritto nel giuramento di Ippocrate. Questo per l'Italia, un commento, Robert, tuo.
Thank you. So I consider Secretary Kennedy to be a personal friend. We speak fairly frequently, and occasionally he asks me for advice. I'm very honored when that happens, and I do my best to give him honest advice. He's speaking of something that I mentioned earlier, the redirection of the attempt to redirect both the government side and the private side of the American medical system to focusing on patients and empowering the physician-patient relationship. The point is that classically in Hippocratic medicine, the physician should be treating the patient that is right in front of them and considering their best interest. Now, what the Secretary is referring to is some structural things that have developed in the American healthcare system. Maybe some of them have happened here in Italy also, in which there are incentives for physicians to follow insurance industry guidance, public policy guidance from the central government, including, as you'll recall, the pronouncements from the director of the CDC, Rochelle Walensky, and from the director of the National Institute of Allergy and Infectious Disease, Tony Fauci, and the advisor on chair of the COVID Commission under Biden, Deborah Birx. And these individuals who really weren't well versed in global consensus about how to manage epidemics, as opposed to people like Martin Kulldorff and Jay Bhattacharya and others that are the authors of the Great Barrington Declaration. They unilaterally decided on policies that seem to then have been aped by the World Health Organization and propagated through Italy and across the world. Those policies were not consistent. The shutdowns, the lockdowns, the closing of the schools, the barriers to transportation, the 6-foot distancing, the use of particle masks that are intended for carpenters to prevent respiratory material like dust. None of these things were the consensus responses to a infectious disease outbreak prior to COVID. They were all created de novo as new policies, and the data are in that they were amazingly counterproductive. They didn't help, they hurt. Part of how that was reinforced in the United States was that the federal government provided financial incentives to hospitals and physicians to implement certain centralized treatment protocols. And this has become the norm in American medicine. I hope it isn't the norm here in Italy, but I fear it might be, where the government says to physicians, this is how you shall treat your patients, and doesn't listen to those physicians that have been testing out alternatives and finding that they're more effective than the official government policy. In the United States, those government policies were reinforced with money, with financial incentives, and also reinforced using propaganda, censorship, and modern military psychological warfare technology on the very physicians that were just trying to find a better way to save patients' lives and prevent sickness. That's what happened. Secretary Kennedy is very aware that that's what happened. And he is committed to, as I mentioned, not just putting the patient back at the center of the physician-patient relationship, as opposed to the government public health officer who's making decisions based on utilitarianism and the greatest good for the greatest number. He's committed to putting the patient back at the center of the medical interaction and creating incentives for that to happen. He's also focused on, he didn't talk about in that talk, but he's very focused on recognizing that we have a system in the United States, and I think throughout the West, not so much in Africa and China maybe, and some other nations that have other more traditional medicine practices, but in Western medicine, we're very focused on treating disease, not on promoting health. And what we've learned in the United States is, by the way, we spend far more, this is something that you Italians can be happy about. We spend far more than you do per person on health care, and we have worse outcomes. As the president has pointed out, if we don't do something in the United States, not only will we hemorrhage money, which is happening, but our children will live shorter, sicker lives than their parents. That's where we're at. That is the essence of what the Make America Healthy Again movement is about, and I think this embryonic Make Europe Healthy Again movement shares that agenda of trying to refocus truly to health care and health promotion rather than medical management with pharmaceuticals. So that's kind of the core of what the Secretary is pointing to, is that he and his colleagues are using a number of methods, including artificial intelligence, to discover these perverse incentives that have distorted patient care, and eliminating those and redirecting the incentives for the average physician. Remember, the average physician doesn't have the time to understand the nuance of RNA technology and pseudouridine and self-replicating RNA. They just kind of know what everybody else knows that's being promoted in media and promoted in government policies, And they do their best to apply that to the best of their ability. These are not evil people. They're people that want to help their patient. They're just, in some cases, not informed about what's going on for various reasons. And so the Secretary is trying to change that. And I think that there may be some opportunities for your government and your public health system to watch what is happening in the United States and decide if any of those things might be helpful here in Italy. It's your decision, it's your health, it's your children, but that's the approach the Secretary is taking, and he is getting an amazing amount of pushback from the media. You would think that we could all agree that we want our children and our parents to be healthier, and that we all wish to live healthier, longer lives. But for some reason, there seems to be these incentives to maintain people in a chronic illness where they can continue to be treated with petroleum-based products and biologics. And the Secretary is, I can speak not for him, but with confidence, that he is absolutely committed to doing anything he can to change that, but it is going to take time. Many people are frustrated. The mRNA products are still on the market, but they now, thanks to the Advisory Committee on Immunization Practices and the Secretary and the Acting Director of the CDC, those are no longer recommended in the United States. They are in a category called shared decision-making. What does that mean? That means that when the patient wants to have or is thinking that they need to have a COVID vaccine, they're to have a real informed consent discussion with their physician about whether or not that is the best thing for them to do given their age, their risk factors, et cetera, so that an informed decision can be made. So we're, in the United States, the Secretary is committed, I can say this because he says it publicly, he's committed to not taking anyone's vaccine away, but to no longer have this situation where the public health infrastructure is pushing vaccines on everybody, but rather informing patients about the risks and benefits of vaccines and their physicians so that they can make informed choices about whether that product is the best thing for them at that stage in their life. And I think that's a mature, responsible position to take. But once again, in the world where we have a regulatory agency, two of them, the FDA and the CDC, both promote vaccines and medical products, and they regulate them. And when you have both of those things living in the same house, you have a conflict. And for some reason, the budget for promoting the medical interventions is much larger than the budget for regulating them. And as you correctly point out, as if that isn't bad enough, at the FDA and I think in the EMA, I learned, the regulators are getting paid by the people they regulate. And of course, this was all justified for the best reasons. You shouldn't have to pay through your taxes for the cost of regulating the pharmaceutical industry, but I'm reminded you get what you pay for. And if you're not going to pay, and the pharmaceutical industry is going to pay, as you pointed out, there's a phrase, the new golden rule. Those with the gold make the rules. And that seems to have been the case with this creeping corruption that you correctly identify, where we have the phrase in the United States is a revolving door. like in a hotel, where people advance their career by working for the government, and then they leave the government and go to work for the agency, for the industry that they were formerly regulating, and then exploit all their connections back to the government and their experience to advance the industry's interest. And that's a hard problem for us to solve in the United States, because we believe that people should be free to be employed by whoever. And so we have a problem in imagining how that system might be fixed. I don't know if you have the same constraints here in Italy, but it is clearly a problem. And what you were referring to was Dr. Peter Marks, in particular, I think, who is the former director of the Center for Biologics Evaluation and Research, who was really the one responsible for the FDA authorization of these genetic vaccine products, who had no background in this technology. He's, I think, a cardiologist, but this is not his core competence. But under his guidance, the people that did have that competence felt that they had to leave the FDA. And he was the one that kind of unilaterally authorized dropping the regulations, not enforcing them, not enforcing the gene therapy regulations, and denying that there were these problems. And then once the new administration came in, he decided that it was no longer a friendly environment, I guess, resigned and went to work for Lilly for a very large amount of money. So it is a problem. It's clearly a problem. Maybe it even exists in Europe. I don't know how to solve it. But as the Secretary said, he's very focused on identifying where those problems are. And in the case of the Centers for Disease Control, where I work, there is a culture of promotion of vaccination. It's almost a cult of belief that all vaccines are safe and effective, and that they are saving lives by actively promoting these products. They truly believe so firmly that all these products are safe and effective, and they shouldn't be questioned, because if you question these products, that will cause vaccine hesitancy, and vaccine hesitancy will result in loss of life. And so that's the logic under which your physicians were censored, is that by questioning the safety and effectiveness of those products, they were causing death due to vaccine hesitancy. And I think that's a global problem from the WHO down. And at least in the United States government, the Secretary is addressing that by making CDC employees that share this redundant, and then creating an opportunity to hire new staff that are focused on the science and the data and less on the cult of vaccination.
Un applauso. E prima di dare la parola, cioè di chiedere al pubblico se vuole, se ci sono delle domande da porre. Sì, allora arriva, ha alzato la mano, quindi c'è qualcuno che lo fa. Aggiungo questo su questo tema che è centrale, quello che ha sollevato il segretario Kennedy e rilanciato qui l'amico Robert, sulla problematica dei conflitti di interesse, delle porte girevoli, eccetera. Dobbiamo parlarne in maniera approfondita, ma permetto, come dire, poi ne parleremo dopo, non è questa la sede, ma essendo stato per 26 anni nella dirigenza degli ordini dei medici, qualche idea di come si potrebbe fare per garantire da una parte la libertà di azione delle persone, ma d'altra parte bloccarli sull'etica e la responsabilità delle decisioni che prendono? Qualche idea me la sono fatta, ne parleremo, sappiamo insieme domani, stasera, domani, dopodomani, abbiamo tempo per poterne parlare, ti trasferisco qualche ipotesi di idea e non c'è una soluzione, ma è un problema che tutti insieme, come per le altre questioni che ha detto che devono essere risolti, i biolab di biosicurezza di livello 4, le armi biologiche, tutte queste cose bisogna fare dei ragionamenti seri, perché ne va proprio dell'esistenza non del pianeta, ma della vita sul pianeta, perché la vita ha la capacità di riprodursi e quindi è una cosa che è al di fuori delle nostre capacità di comprensione logica e non empatica. Medico, empatico, idea. Da dove ti arriva l'idea non si sa. Poi ne parleremo. Allora c'è Andrea, ok, prima il dottor Stramezzi.
Robert. Can you hear me? Mi sentite? No? Sì. Buonasera Robert. Io ricordo bene che quando ci siamo conosciuti, ci siamo poi rivisti a Bruxelles, al Parlamento europeo, abbiamo parlato molto delle cure per il Covid, che noi conoscevamo già a marzo, a metà marzo del 2020. Io avevo già curato dei pazienti a casa, poi in ospedale, e che soprattutto ho mostrato il protocollo del Papa Giovanni XXIII di Bergamo, dell'ospedale, che diceva esattamente le stesse cose, che i pazienti andavano curati a casa con antinfiammatori, con azitromicina, idrossiclorochina e poi con cortisone ed eparina. Le linee guida erano altre, lo sappiamo, l'attesa, poi la tachipirina, il paracetamolo, poi il Paxlovid e tante altre cose che non servivano a nulla, anzi che creavano danni. Io penso che questo sia il vero problema, le linee guida. Le linee guida tolgono la libertà al medico, ne abbiamo parlato prima, ne avete parlato prima, perché demagogicamente è giusto che un contadino dell'Iowa possa avere la stessa terapia che ha un produttore cinematografico a Beverly Hills. Però non è lo Stato che le deve dettare. Lo Stato può dare dei consigli, ma non devono essere dettati. Io adesso sto affrontando centinaia e centinaia di casi di turbo cancer, ho cambiato modo di curare le persone, adesso mi sto occupando di questo, e chiaramente non sto seguendo le linee guida. E devo dire che abbiamo dei successi con nuove molecole e nuove sperimentazioni. Il nostro governo, che speravamo e pensavamo che avrebbe cambiato le cose, dopo quei 2 drammatici governi che abbiamo avuto in pandemia, invece ha fatto un progetto di legge su uno scudo penale per tutti i medici, non solo più per le aziende farmaceutiche e per i medici vaccinatori, ma per tutti i medici a patto che seguono le linee guida. Questa è una cosa criminale, perché vuol dire che se io ho 100 pazienti e li curo con le linee guida e muoiono tutti e 100, non mi succede niente. Se io invece quei 100 pazienti non li curo con le linee guida e me ne muore uno solo, magari perché ha un cancro molto avanzato, io rischio la prigione. Questo è, secondo me, un punto che bisognerebbe far cambiare. E grazie anche a voi negli Stati Uniti e ovviamente al segretario Kennedy. Grazie.
Can I just say one thing? This doctor has been extremely brave. I've followed him throughout this. He has gone above and beyond the call of duty. He's even, as I recall, traveled to Canada to save the life of a colleague in the face of all of the pressure and censorship and defamation. And I honor you for your courage and for your commitment to your oath as a physician and your example and leadership of committing yourself to the patient not to the system.
Domanda? Un attimo, c'è con la signora.
Buonasera, dottor Malone, grazie per essere ancora qui con noi in Italia. Io sono Cristina Costa e sono un'attivista del movimento Popolo delle Mamme, giù le mani dai bambini. Noi ci occupiamo della vaccinazione pediatrica qui in Italia e ci rendiamo conto di come il problema dell'autismo in Italia sia esploso, seguendo un po' le dinamiche negli Stati Uniti, dove c'era, diciamo, una vaccinazione massiva, e qui in Italia, dopo il protocollo della Lorenzin, abbiamo seguito una esplosione, un'epidemia di autismo. Non solo questo, perché il consigliere dell'EMA, dottor Piscitelli, qualche tempo fa, proprio qui al Senato, ha detto che in Italia abbiamo il doppio dei casi di tumori infantili. Ora, la conferenza del 22 settembre fatta da Kennedy e dal presidente Trump ci ha regalato lo sdoganamento della verità su questa materia, su questo tema. E sono state fatte tantissime affermazioni importantissime che correlano l'autismo con la vaccinazione pediatrica, facendo riferimento alla comunità Amish, che noi sappiamo che il professor Steve Kirsch della Pennsylvania ha ben documentato, e non solo lui. Ha fatto riferimento a uno studio straordinario fatto dal dottor Zervos, che era stato occultato volutamente dal sistema delle porte girevoli, come dice lei, del CDC americano. E quindi c'è stato proprio un sistema di premialità verso chi faceva tutte queste vaccinazioni, che poi ci chiediamo se siano veramente utili, che non sono assolutamente sicure, come ha detto anche l'avvocato sempre al Senato americano Aaron Siri, e quindi diciamo che finalmente anche noi respiriamo verità grazie a tutto quello che si sta scoprendo in America, negli Stati Uniti. Ora la domanda è questa: avremo bisogno anche noi di un Kennedy, avremo bisogno anche noi di un Trump, ma non ce l'abbiamo. Cosa sta cambiando comunque in America e come possiamo fare Make Italy Healthy Again? Grazie.
Thank you for those kind words of support for the President and the Secretary. I'm not speaking on their behalf, but I'm grateful for your comments. Let me caution you a little bit. Forgive me. The issue of the correlation between vaccination and pediatric tumors and vaccination and autism is an association. There are data associations, and one of the things that I think we have learned, if we've learned anything from COVID, is that we have to be very careful about concluding that correlation is the same as causation. So when we see data, let me just illustrate this. What the President and the Secretary actually emphasized in that meeting, yes, they did acknowledge that possibility of the correlation between vaccination and autism, for example. And there are studies that suggest that that's the case, and then there's other studies, maybe they're flawed, that suggest that's not the case. But in any case, it's clear that there is the data are noisy enough that the President and the Secretary were not able to conclude at this time that there was a clear correlation between vaccination and autism. They did conclude, and this is quite controversial in Europe, I understand, and in the United States, they did indicate that the data, the large, big data currently being examined in the United States indicate that there is some correlation between dosing of what you call paracetamol, what we call Tylenol, the generic term is acetaminophen, and attention deficit hyperactivity disorder, or ADHD, in the young child, and to some extent, some aspects of the autism spectrum disorder, which is a very broad category. There is also compelling mechanistic data in peer-reviewed literature having to do with the mechanism of action that's known for acetaminophen and acetaminophen toxicity and neurologic damage. So let me use this. So those data exist, and they're noisy because a lot of those data are based on coding for whether or not a pregnant mother or a young infant has received acetaminophen or paracetamol. And in the United States, and I think Europe also, acetaminophen is over the counter. So it only gets coded in the medical databases if there's a prescription or there's some clinical note that it was used. But most cases of acetaminophen use are over the counter. So the data are noisy. Now, just for the sake of discussion, I don't know about Italy, but in the United States, historically, parents have been, and pregnant women, have been encouraged to treat fever, even mild fever. And they've been told that the best of a bad lot in terms of the anti-inflammatory drugs is what you call paracetamol or acetaminophen. Now, just to illustrate the point, not saying this is what's going on, one of the most common adverse events associated with vaccination in the child is fever. And what do you treat fever with? You treat fever with acetaminophen. And so it could be that at least part of that signal that you and others suspect indicates causation between vaccines and ADHD and autism spectrum disorder may be actually a correlation that is influenced by this tendency to reflexively dose with acetaminophen to treat the fever. And underlying that as a fundamental medical principle is that fever actually is beneficial in some cases. And maybe we should be a little cautious about treating fever. It's happening in the patient for a reason. Now, if that patient has an underlying condition like a growing ascending renal infection, that needs to be treated promptly and not with acetaminophen. It needs to be treated with the proper drug. So I suggest this just illustrates the point that this type of epidemiologic data are very complex. And there are often unintended, unrecognized confounding variables that are influencing the signals that we're observing. And we are quick to criticize our colleagues in public health for over-interpreting their epidemiologic data. And I think that we all need to take a lesson from that and recognize that epidemiologic data are subject to confounding variables that are often very hard to detect. So in the case of vaccines and autism, it may well be that there is a strong correlation and that it's causative. But it could be that it's indirect because we treat certain types of vaccine adverse events with agents that do have a clear mechanism of action that can impact on neurodevelopment and are associated in some cases with these neurologic symptoms like ADHD and ASD. So I'm not saying that's the case. What the president and the secretary have said very clearly, and then Bobby reinforced in a subsequent press conference and release, a reel on social media, is that the data are fairly strong regarding the interaction of paracetamol or acetaminophen and these neurologic defects in the growing fetus and the newborn.
Without fear.
That it's not yet definitive, but the big data analysis are strengthening that signal, are making it appear as if that is more and more likely to be a correlation. And what the secretary's position has been is that out of prudence, it's best to minimize the use of paracetamol or acetaminophen during pregnancy, particularly the third term, and in the newborn, in the young child, recognizing that there are cases where you have a malignant fever, or you may have febrile seizures, and it's medically necessary to treat those things. So that's his position, is to be cautious and not to reflexively use paracetamol or acetaminophen in every case of fever in the third term and in the newborns. Now, you talk about bigger issues about the vaccine schedule, I think. And I think I can say, because the president has disclosed it, there are many things that I can't talk about that are in progress at the ACIP because those are the rules. I can't talk about current things that are not yet public. But the president has said explicitly that he wishes to have the entire childhood vaccine schedule reevaluated. And so you might imagine that the Advisory Committee on Immunization Practices, whose job it is to basically advise the president's designee, who's the director of the CDC. That's our job. It's not to set vaccine policy, it's to advise the director. That's a political decision. Vaccine policy in the federal level is a political decision. It's not for scientists or physicians to set public policy. So we advise the director of the CDC, but you could well imagine that the ACIP is listening to the president and is likely to be making a comprehensive analysis of the childhood vaccine schedule and vaccine-vaccine interactions, which has never been done. So hopefully, if that's going to happen, it might happen over the next year. I'm sorry it can't happen faster. We're pedaling our tricycle as fast as we can, given the resources that we have and the fact that we have to operate in an environment where many of the support staff at the CDC are don't agree with this agenda. So that's where things stand. And hopefully, as these studies develop, and there are many, the Marty McCarty at the FDA has disclosed, so I can disclose to you, that there is an ongoing investigation of pediatric deaths associated with the COVID-19 vaccine at the FDA based on the CDC data. And I have seen the preliminary results from that, but they're not yet public. The director of the FDA has decided not to make them public yet, so watch for that. And watch for what data we are able to disclose about the risks and adverse events of these products. And hopefully we will apply well-established, scientifically rigorous processes to evaluating the safety and effectiveness and modifying the recommendations for these various products. Over the next, we basically have 3 years to do this job before there's a change in the administration, unless the Republicans lose the midterms. So that's where it's at, and hopefully as we disclose those findings, and the Secretary allows those findings to be disclosed, you here in Italy might benefit from that and use those findings in your own discussions within your government. Have I answered your question?
Sì, domande? Oh, no.
Robert, both of you, thank you very much for interesting talks. I want to ask you specifically, Robert, whether you think enough is being done to emphasize the importance of natural immunity, because we evolved as a species, as did other mammals, without vaccines. And it's not entirely clear that vaccination has actually had a major, for big diseases, has had a major effect on mortality rather than improved hygiene. And so that for example, I would say that the arguments about acetaminophen or paracetamol might well be because of the action on the liver of 25-hydroxylation of vitamin D. As you know, I got into this and have co-written 2 books, not peer-reviewed, but hopefully criticized, on vitamin D. First of all, the role of D deficiency in COVID-19, which was obvious, and now in its potential role in vaccine, pseudo-vaccine damage. And just one final little point is that vitamin D, its activated form, induces its own destruction. It's one of more than 1,000 enzymes that are coded for through the vitamin D receptor is 24-hydroxylase, which creates what, as far as we know, is an inactive form of activated vitamin D. And that's very important in preventing hypercalcemia from various causes. So, you know, I would argue very strongly for many more studies of basic physiology, not, you know, the 1,000 patients. You don't necessarily need that when you're dealing with critical substances such as vitamin D in its active form on natural immunity. One very final point a question I want to ask you. You haven't mentioned the role, or maybe you have, maybe I was asleep, the role of patents, brevetti in Italian, because in the case, and I've helped Joseph submit a bid against 10 or 11 people that we have identified as being important in constructing a virus. And in fact,
we have several questions. So please try to let Robert to answer, because we have several questions. So go to the questions.
Right.
Okay, so
yeah,
let's see if I can hit these quickly. Natural immunity was overlooked as a policy position during COVID. That we can't deny that. And that has now been well documented. Will that happen in future outbreaks or public health responses? One hopes not. The cynic observes that the financial pressures are such that it may well happen again. Is there an interest in an openness to promoting a variety of supplements, of which vitamin D is one, that may augment or support immunologic health that is absolutely at the core of the Make America Healthy Again agenda. And it's consistent with this focus on promoting health as opposed to treating disease. Regarding vitamin D, quickly, I had I'm going to share an anecdote briefly. During the COVID crisis, I was approached by a military physician who had done key studies on behalf of the U.S. Army in which they had supplemented meals ready to eat with vitamin D. And they were able to document that the incidence of viral disease symptoms and lost days from warfighters was significantly improved with the addition of vitamin D3, I think it was, in these meals ready to eat. So the Army asked this physician, he shared with me the personal experience. The Army's response to these data was, this is really not in our core competence. You need to go talk to Dr. Anthony Fauci. He literally was told to go talk to Fauci about this important new data. And what he shared with me is that he presented the data to Dr. Fauci, and Dr. Fauci's response was, we treat infectious disease with vaccines, not with drugs. So there appears to have been a systemic denialism about the potential benefits of this key signaling molecule, often best administered with zinc because of their synergistic effects. And I acknowledge your leadership in alerting the world to the importance of vitamin D, and particularly vitamin D3, in supporting immune system health. We are now, because in the United States, we have a relatively unregulated nutritional supplement industry, there is significant financial competition to identify natural substances and supplements. And this is giving rise to many other agents, and one that we just published on has to do with a lipid-like molecule produced by gut bacteria that also seems to be supportive of immunologic health and able to reverse immunosenescence, which is a major problem. This is the aging of the immune system, which is part of what drives the increased risk of infectious disease in the elderly. So all that's happening. Now, the patent issue is a major problem, and it is in many ways at the root of the corruption of academia. And as somebody who is, my career coincided with the rise of this thrust to patent everything that has distorted the entire academic enterprise because it's all about money. And I concur with you that that's a deeper issue. It's not one that I've heard Secretary Kennedy address, and probably it is something that should be addressed, but in the United States, that would have to be done at the level of Congress. It's not something that the Secretary or the President could just wave a wand and fix. So thank you for raising that, and I hope I've answered your questions as quickly as I can.
Un'altra domanda, abbiamo ancora 3 o 4 domande e 25 minuti, quindi prego di andare rapidi alla domanda in maniera da lasciare il tempo al professor Malone di poter rispondere esaurientemente.
Grazie professor Malone di essere qui, e ringraziando lei ringrazio anche tutta la nuova amministrazione della salute americana che ci sta finalmente dando un po' di luce in questi 5 anni. Io sono un avvocato, ci sono altri avvocati in questa sala con me e stiamo particolarmente combattendo in Italia per la situazione che si è venuta a creare per i sospesi che hanno esercitato il loro diritto di non vaccinarsi e si sono trovati per mesi, se non per anni, senza privati degli stipendi. La mia domanda rispetto al livello altissimo scientifico della sua trattazione le sembrerà basica, ma purtroppo la giustizia italiana in questo momento è ancora su un livello estremamente basico. E la domanda è se da parte sua, da parte dell'amministrazione americana, è stata acquisita in maniera chiara e certa l'evidenza che i cosiddetti vaccini contro il Covid non proteggevano né dalla diffusione del SARS-CoV-2 né dalla contrazione eventuale della malattia. Perché noi in Europa abbiamo avuto delle dichiarazioni, alcune fatte dalla rappresentante per l'Europa della Pfizer al Parlamento europeo, anche l'EMA lo ha messo per iscritto a una commissione di parlamentari europei, anche in Italia una nostra agenzia pubblica lo ha scritto, ma il governo non prende atto di una cosa che sarebbe importantissima, cioè riconoscere che questi prodotti, magari fatti con le migliori intenzioni, ma non bloccavano il contagio. Ecco, io le chiedo e la ringrazio tantissimo se potesse dare la posizione della sanità americana su questo aspetto. Grazie infinite.
So you said your primary thrust in your question was the prevention of transmission. And you'll recall, we all do, from early in the outbreak, the promoted narrative was that if you accept these products, you would be protected and you would help protect all of those around you because it would block the ability of the virus to replicate and spread to others. But then you also added the word disease. The data on reduction in disease severity are not as clear-cut, and prevention of death. My impression of the data is that it's very dependent on when you sample that question. So it appears that these products provide some short-term benefit for disease and death, but there are multiple data sets indicating that at something between 3 and 6 months after administration, patients may develop what's called negative effectiveness, which is to say that they actually paradoxically become more likely to have disease or death than those that did not accept the product. Now, the confounding variable is that in the midst of all of this, we had natural infection with natural immunity developing. So it's hard to, the data are murky. So I personally recommend that we be a little more cautious, and since you're an attorney, you have to be very cautious about your statements about disease and death. Of interest in that, speaking to you as an attorney, as a legal professional, I think it's significant that at least in the United States, the FDA authorization was for prevention and spread of infection. It was not for reduction of disease and death. So this is a secondary claim that's not actually supported by the regulatory authorization. This is a claim that has the appearance of having been a convenient cover for the fact that the true indication of prevention of infection and spread failed. And that's undeniable. And so I've provided sworn testimony, as have many others, that supports your position that if the justification for the mandates was to prevent infection and spread, then that's inconsistent with the actual data. And the case can be made that that endpoint, if that's the desired endpoint, it could be more readily achieved through detection and short-term quarantine rather than infection. That's actually a more effective, and that's backed by NIH data. So I concur that that's one of the narratives that were false.
Grazie. Due domande lì in fondo. Ah, ok, Alberto.
Volevo sapere cosa ne pensa di questa possibilità per venire fuori da un problema che ha posto. Ha detto giustamente che la correlazione tra paracetamolo e autismo, piuttosto che disturbi dello spettro autistico, non può essere di per sé prova di causalità. La stessa cosa, anche se la correlazione è molto più forte con vaccinazioni ripetute, in particolare alcune, faccio l'esempio dell'antiepatite, allora per venirne fuori in maniera scientificamente inappuntabile ci sarebbe una cosa che tutti dovrebbero accettare all'interno della comunità scientifica, un trial randomizzato, pragmatico, prolungato e di ampiezza sufficiente. L'obiezione che viene abitualmente fatta e non si può fare per motivi etici. Bene, come aggirare in maniera pulita eticamente questo problema? Una ipotesi è quella di fare informazione in contraddittorio in un paese con 340 milioni di abitanti come gli Stati Uniti. Non è difficile, anche dopo aver sentito tutte le campane a favore o contro, avere centinaia di migliaia di persone, se non milioni, di esitanti che non sanno se prendere il paracetamolo quando hanno la febbre in gravidanza o non prenderlo, fare o non fare la vaccinazione antiepatite B. Bene, offrire agli esitanti la partecipazione a un trial randomizzato, pragmatico, per far progredire la scienza, potrebbe essere il modo per neutralizzare le obiezioni di tipo etico, perché loro comunque non sanno da che parte buttarsi, e fare effettivamente progredire nel modo che a tutti sarebbe accettabile la scienza, purché i ricercatori che partecipano fossero rappresentanti di entrambe le correnti di pensiero, di modo che quello che viene fuori da una ricerca di questo genere non venga poi contestato dalla parte che esce perdente.
So you're speaking as somebody who spent most of his career as a vaccine developer. I was in somebody who was repeatedly trained, because I did clinical research, in the fundamentals of, let's say, 20th century bioethics. 21st century bioethics is different now. This is the new utilitarian bioethics. It's very different from the old Hippocratic Nuremberg-based bioethics of the 20th century. But that's my training. And I was taught exactly what you refer to, that it was fundamentally unethical to run a vaccine trial in which one had a placebo control, because you would be exposing, in many cases, children to a risk of that infectious disease for which the vaccine is targeted. This is very akin to the logic of Dr. Fauci during the early COVID vaccines, where he reported, together with Pfizer and Moderna, a subset of the data analyses that made the vaccines look very good, but not the other types of data analyses that didn't make them look so good. Then when the data using this kind of biased reporting approach looked very strong, 98% protection, you remember? He then decided that it was no longer ethical to maintain the control group, and they all had to be vaccinated. So even in that case, ethics was weaponized to justify what appears to be an intentional suppression of longer-term safety data that might have been, would have informed decision-making about these products. You raise the possibility that since there are vaccine-hesitant people, and in the United States it's over 50% of the population now, because of the policies that were used during COVID, are vaccine hesitant. That the vaccine hesitant might serve as an appropriate control in a true randomized placebo trial. So let's look at that for just a moment. One of the problems that's become really clear in analyzing vaccine data having to do with safety and effectiveness is something called healthy vaccinee bias, in which those that accept the vaccine are generally highly compliant and often more healthy. For some reason, the folks that are skeptical of vaccines, perhaps because they are less healthy and maybe have had issues with the medical care system, for whatever reason, those that don't accept vaccine tend to be less healthy. And so right off the bat, this healthy vaccinee bias results in skewed data, whether it's epidemiologic or randomized clinical trial data. What's become clear is that this gold standard of placebo-controlled randomized clinical trial structures are subject to a variety of forms of manipulation, including enrollment criteria. And so although we're taught this is the gold standard, in practice what we're learning is that clinical research organizations, pharmaceutical companies, and others that have a particular agenda have a variety of ways to manipulate the outcomes of randomized clinical trials, even the ones that are placebo-controlled. So I don't know that that logic that you shared, which is kind of conventional wisdom among many, and you'll recall that Secretary Kennedy has long maintained that, with the exception of the COVID vaccines, none of the vaccines in the pediatric schedule had a true placebo control. They were typically all tested against other vaccines, and so if those other vaccines have background adverse events, and you compare the new vaccine to the somewhat reactogenic old vaccine, maybe of a different type, then you're biasing towards concluding that the new vaccine is safe because you're comparing it to something that already has adverse events. So that it may be that the best approach is a big data approach, in which one takes real world data and of very large numbers and analyzes that with modern data tools, doing your best to remove confounding variables and assess, but the core underlying problem, there's no question that there has been creative clinical research that is biased towards the interests of the manufacturers. Of course it is. Why would you expect anything else? They're making money from it. Underlying this is this new logic that, again, it's like the regulatory affairs. You get what you pay for. If the public wants to have rigorous objective data in order to make informed decisions about their own health, they can't rely on the manufacturers to generate those data, because the manufacturers have a vested interest in skewing the data to support their product. So the public is going to have to step up to the bar and pay if they want to have good data. And even then, because of these confounding variables like healthy vaccinee bias, it can still be really hard to get that. So that's the real world. And I can tell you that at the Advisory Committee on Immunization Practices, this is right at the center of our dilemma in evaluating all these products, is this wide range of confounding variables and complexity and biases that exist throughout the entire database on vaccine safety and effectiveness, particularly since many of these are legacy products that were licensed in the 70s when standards were abysmal compared to now. The study sizes were tiny, the rigor was not there, statistical rigor, et cetera, follow-up. It's a major problem that you're speaking of, and I wish it was that simple that we could just say those, whether you're Amish or some other religious order or other community that elects not to accept vaccines and use those as a comparator, that there's this underlying hidden bias problem that makes it really hard, which is why, again, I don't want to disclose prematurely, but there is an argument to moving towards risk-based analysis in decision-making. So instead of just relying on on evidence-based medicine, which we've now learned can be readily perverted, it sounded like a great idea, relying more on multifactorial analysis of risk that integrates animal studies, epidemiologic findings, frontline physician observations, respecting case reports and case series, not discounting them, and presenting them to the patient as more of a comprehensive informed consent document like you might have for a clinical trial, in which the potential risks are enumerated and the patient has the opportunity to process those, ask the physician, have an interaction, and make a decision about what's best for them. And maybe that's the only way we can get out of this. I don't know. But what you're talking about is a fundamental problem.
Sì. Abbiamo due domande, basta. Abbiamo 10 minuti, nemmeno due domande. Rapida, Roberto.
Sì, allora, la prima...
una.
No, io sono un medico di base e ho delle difficoltà. Alla prima domanda, cioè, mi ha già risposto dicendo che praticamente c'è un pregiudizio, perché io come faccio a consigliare a dei pazienti di fare o di non fare se ciò che mi si propone è sotto un segreto militare? Cioè, non ho la libertà di capire. La seconda cosa, il proposito del paracetamolo. Almeno in Italia il paracetamolo ormai è nascosto in un altro antidolorifico, di cui non mi ricordo il nome, e se me lo ricordassi è bene che non lo faccia, non me lo ricordo. Comunque il paracetamolo viene somministrato fraudolentemente in un altro antidolorifico. E l'altra cosa, io come medico mi vergogno di avere uno scudo penale perché mi si tratta da cretina.
So I'm not sure what the question is. I don't think you're a stupid person. I think it sounds like to me like you're a good doctor and you're acting in the patient's best interest. It may be that it may be that this is hidden intentionally, or it may be that the pharmaceutical company that's manufacturing it, by combining it with another drug, is able to create a proprietary product that they can make more money on. And that's capitalism. But I hope that in Italy you have packaging labeling, I suspect you do, that would require the ingredients to be listed on the package insert or on the box, that would include acetaminophen as one of the ingredients. Let's be careful and remember what the Secretary said. This is a correlation. It appears to be a strong correlation, but it's not proven to be causative. So the Secretary's recommendation is to be cautious, to to reserve the use of paracetamol and paracetamol-containing products for when they're absolutely necessary, but recognizing that in pregnancy and in the infant, the alternatives are typically even more toxic. So you're in a bad position as a primary care physician. You have to give something that is not perfect, but sometimes perfect is the enemy of the good. So you have no choice. And so you have to be prudent and caution your patient to use as little as necessary to prevent the clinical symptom that you're treating, keeping in mind that fever is an indicator, can be an indicator of more important medical problems, underlying problems. I mentioned ascending renal infection, but there's, a pulmonary infection, et cetera, ear infection. These common pediatric problems that you're much more familiar with than I am. So I just want to emphasize, number one, it should be on the package or the package insert. And number two, sometimes you just have to go with the drug that isn't perfect. And that's kind of almost always the case, as you know. All drugs have toxicity. And in the case of acetaminophen, it may be that we have a dose-dependent effect, let's hope. And that by minimizing dosing and minimizing in particular dosing during critical developmental windows like the 3rd trimester and to some extent the 2nd trimester and in the neonate, this is as was pointed out, the developing fetus and the neonate have very immature livers. They also have very immature brains. And so it could be that they are particularly susceptible to the glutathione depletion that can be associated with acetaminophen due to the use of glutathione in the liver to metabolize the acetaminophen. That seems to be the mechanism. It's plausible. And so what that would teach is that we need to be very cautious in the developing fetus and neonate. And we need to be aware that repeat dosing may well have a cumulative effect. Does that help?
Domanda in fondo.
Buonasera, sono Fabrizio Bonanni Saraceno, avvocato e giornalista. La mia domanda parte da un presupposto. In Italia, anche se non si conosce molto bene, abbiamo un articolo, un principio fondamentale che è il diritto alla salute. L'unico a essere fondamentale ma anche inviolabile. Ecco, noi abbiamo avuto lo Stato che l'ha violato, l'ha mortificato e violentato. E le spiego perché. E la domanda è questa. Partendo da dei fatti, cosa sarebbe accaduto negli Stati Uniti se un medico come lei avesse detto davanti una commissione d'inchiesta parlamentare per la pandemia da Covid-19 che riceve finanziamenti diretti dalle stesse case farmaceutiche che hanno prodotto, non dei vaccini, dei farmaci anti-Covid dove c'è stata l'obbligatorietà della somministrazione. Cosa sarebbe accaduto se questo medico, che noi ben sappiamo e la stampa non ha divulgato come uno Stato civile liberale di diritto avrebbe dovuto fare, se questo medico fosse stato onnipresente in tutte le TV delle massaie, delle casalinghe, a dire che era sicuro, quando noi sappiamo che la scienza non è una fede, non è un dogma, ma si basa sulla sperimentazione. Ma soprattutto, io non sono negli Stati Uniti, ma in Italia c'è l'articolo 32, diritto alla salute, che oltre a essere fondamentale è inviolabile. Cosa sarebbe accaduto, e finisco, se un tribunale degli Stati Uniti, civile, corrispondente a quello italiano, ovvero di Asti, avesse sentenziato, quindi non è un'opinione di un Novax o di un complottista, avesse sentenziato che esiste che sussiste un nesso eziologico fra la somministrazione del farmaco anti-Covid e l'insorgenza della mielite traversa che ha portato a una paralisi degli arti inferiori, cosa sarebbe accaduto da un punto di vista giuridico, giudiziario, medico e mediatico negli Stati Uniti? Perché vede, io da italiano mi accorgo che in questo paese si va in piazza per errore di un arbitro in una partita calcistica, ma non si va di fronte a queste notizie che sono sconvolgenti. E mi taccio.
So if I can rephrase your question, what I think I heard you say with great passion is what would have happened if the American judicial system had held certain physicians or government officials or pharmaceutical industry leaders accountable for their misrepresentations. Am I understanding your question? What would be the consequences of that? If I'm understanding your question correctly, one of the things that was done in the United States was historically we created indemnification laws that prevented the industry from being held legally liable. Basically, the pharmaceutical industry, the vaccine manufacturers, told then President Reagan, as I recall, that if he didn't give them indemnification, they would stop making vaccines, and then he would have to deal with the guilt and the political consequences of a surge of pediatric infectious disease. So they basically blackmailed him. You know, it was the phrase that's often used, a nice country you have there, it would be a shame if anything happened to it. I'm holding the gun to your head. That was further amplified by some of the legislation that enabled the pandemic responses that, among other things, created a pathway whereby the government could disregard the fundamentals of informed consent. Basically, the legislature wrote in clauses that allowed the government to bypass informed consent in the event of a declared public health emergency. And so the courts in the United States, I think, have found it convenient to cite historic case law that is over a century old in the United States, that the government has the right to impose quarantines or other measures in the event of a declared epidemic. This has to do with a smallpox outbreak on the East Coast. And to cite that historic precedent as justifying the actions that were taken during COVID. The courts seem to have found it very convenient to avoid taking a position on this. So you had both legal coverage through the legislature and judicial cover, because the courts found a myriad of ways of basically determining that whoever the plaintiff was didn't have standing, and that the attempts to hold individuals accountable were not allowed to proceed. In some cases, this went all the way to the Supreme Court, including the censorship activities. So what would have happened, you speculate, if that had not been the case, and if the courts had not functionally acted to legitimize and support the state as opposed to ensuring justice? We would live in a very different world. But that's not the world we live in the United States. I think, personally speaking for myself, my two biggest disappointments were the failure of let's say, ecclesiastical leadership on morality. And I say this specifically, when we held our first summit here in Rome, I was privileged to speak with Cardinal Turkson about Vatican policy, hoping that Pope Francis might take a position as an ethical leader for the world about informed consent. That did not come to pass. And repeatedly, the courts all across the European Union and the United States have refused to acknowledge the petitions from people like Philip Krause and others, perhaps yourself, to hold those responsible for these breaches accountable. And if they had been willing, if they'd had the spine to do their job, we would live in a very different world. But if wishes were fishes, there would be no poverty and starvation. So it is what it is. I'm very disappointed in the judiciary across the world, and I'm very disappointed in our religious leadership for its failure to provide moral leadership. And we've ended up with a very small number of dissident doctors that have put their careers at risk to counter the approved narratives about these various products. And they were vilified, they were censored, they were deplatformed, they lost their licenses, and they were right. And that's another thing that it seems like there should be some restitution and acknowledgement of, but I don't know how that happens in the political world that we exist in. Maybe this meeting today might be a starting point for that. I'm hearing more and more talk yet again of some sort of truth and reconciliation process that should happen in order for the society to recover. And I think that courageous political leadership could do that. It was mentioned earlier, where is our Italian President Trump and Secretary Kennedy? You have to answer that, I can't. Maybe that person is sitting in this room. But that the speaking about the U.S. State Department policy, the new rule is that the United States will partner unilaterally with other nation states to support them solving their own problems. And this is a problem, this is an Italian problem, it's an EU problem, and the United States should not be the ones. If you want to not be dependent on the United States, then you're going to have to solve it yourself. And I'm pretty sure that the State Department will be glad to partner and support that. That seems to have been their policy. But don't look to the United States to solve that problem, because the American courts are just as compromised as what you're experiencing here in Italy, maybe more so.
Thank you.
Grazie. Non so se potremmo, come dire, sfruttare ancora, perché siamo andati lunghi rispetto all'ospitalità, perché sono le 19:10 e la sala c'è andata fino alle 19. In ogni caso vi ricordo che domani all'Università San Domenico ci troviamo con il professor Malone e altri ospiti, oltre a me, che avete avuto la sfortuna di sentirmi qui. Quindi ci vediamo domani al San Domenico, abbiamo più tempo per parlare. Grazie.